Hello, this is Dr. Tisdall. In leukocyte pathology, we're going to start, as we do with every system, with understanding the key physiologic pathways, which is going to be important in terms of hematopoiesis. In hematopoiesis, we have to be able to differentiate myeloid versus lymphoid cell lines. As always, when we start a new subject, we have to have in our mind the normal physiologic and biochemical pathways upon which we're going to build our understanding of normal function and disease. Figure 8-1.1 is one of those fundamental physiologic cellular development pathways we have to have in our brain. In this we see hematopoiesis refers to all the cells made in bone marrow. We start with a pluripotential stem cell, and then we start with the utter fundamental division of hematology, which is lymphoid versus myeloid cells. Once we come over into myeloid cells, remember, myeloid cells divide into two fundamental families, the megakaryocyte erythrocyte family and the granulocyte monocyte family. And we can see from the granulocyte monocyte family we have innate immunity. Whereas when we come over to lymphoid, we have adaptive immunity. As we go through the next chapter, then, we're going to be discussing the myeloid series with emphasis on the granulocyte and the lymphoid series with both T and B cells. Well, let's start by talking about the neutrophil. Remember that the neutrophil is made in the bone marrow and regulated by the granulocyte colony stimulating factor, or the GCSF. This increases production of neutrophils and, as well, permits their release from the bone marrow. Overall, we see upregulation of our granulocyte stimulating factor by IL-17 from the Th17 lymphocytes. These, in turn, are activated by IL-23 from macrophages and dendritic cells. Let's just put that in a clinical perspective. If I have a serious soft tissue infection in the leg, for example, then how would the bone marrow know that systemic recruitment is required? Well, we start back at the site of infection with activation of macrophages and dendritic cells. These are going to secrete IL-23, which will travel through the blood to the bone marrow, where they will activate our Th17 cells. These will secrete IL-17. This will increase production of our granulocyte colony stimulating factor, and we will get not only expansion of our granulocytic series, but we'll also see increased release from the bone marrow. So that every time you see an increase in neutrophils in the blood, you have to correlate that to the two tissue pools. If we come to figure 8-1.2a, we see these very different pools in which we should think about our neutrophils' actions. If we come over to the right side of the diagram in the tissues, this of course is the end use of neutrophils. The blood where we measure them, in fact, is only a transportation tube for them. There's no significance in the neutrophils we see in the blood except that they start in the marrow and travel in the blood to the tissues. And so we think of our IL-23 as the signal from the tissue through the blood to the marrow, and then IL-17 signaling production of our granulocyte colony stimulating factor to increase both the synthesis and the release of the granulocytes. Note that when we take a look at the development of granulocytes in the marrow, we start with the myeloblast through a promyelocyte, myelocyte, metamyelocyte, band, and then a mature granulocyte. Mature granulocytes are only released at a low level in the absence of signaling that there is a need for systemic inflammation. Within the blood, which is really only about 1% of our granulocytes, neutrophils flow in two pools. There's a central pool, the circulating pool, in which the neutrophils are moving freely. About half the neutrophils, however, bump along and are slightly sticky to the endothelium. This is our so-called marginal pool. Now, neutrophils really only live about 5 days, so there's a tremendous ongoing production and loss. If they are not consumed in a pathologic inflammatory reaction, then after about 5 days they undergo apoptosis. Remember that there's a quantitative relationship of mature to immature neutrophils. In any physiologic inflammation, each stage of maturation, so for example from myelocyte to metamyelocyte, has a greater number of neutrophils in the more mature stage, so that physiologic inflammation would always have more bands than myelocytes. This is going to be important when we come to our neoplasms like CML, where we'll often see loss of this normal relationship, and there might, for example, be more myelocytes than metamyelocytes. And this will give us our characteristic, quotes, myelocyte bulge, end quotes, of CML. Now compare this to the lymphocytes. No, I want to stop. Stop at that point. I want to pick up now from the end of the neoplastic CML, and I want to say, note now the clinical application of our circulating pools of neutrophils that are discussed in our margin. Note that in situations of stress, the release of epinephrine and steroids decrease neutrophil adhesion to the endothelium. So now instead of having roughly equal circulating and marginal pools, we've doubled the size of the circulating pool. And so you can see counts as high as 10 to 14,000 in the CBC. So as a clinical decision, one has to decide, when I see an elevated neutrophil count of 10 or 12,000, how do I tell whether that's a marker of systemic inflammation or merely demargination from the effects of the stress compounds of epinephrine and steroids? Well, there are two basic ways one does it. The first is to show the presence of immature neutrophils. If one is seeing band and metamyelocyte cells, then this clearly represents systemic inflammation with release of those immature cells from the marrow. The other is to show evidence of a acute phase reactant. And there are lots of acute phase reactants. We're going to talk about them in a bit. But the commonest one we use in everyday medicine is C-reactive protein. If neutrophils are acute inflammatory cells, well, lymphocytes are much more from our adaptive immune system. The majority are actually found at the epithelial surfaces because they're much more likely to contact and respond to foreign antigens there. This might surprise you, but if we were to actually take all the lymphocytes out of the body and see where they were, about 80% of all your lymphocytes actually line the gastrointestinal system. Remember that lining any glands, and this includes the GI tract, the lymphocytes are mostly B cells. One of the major ways we control and regulate the environment of glands and lumens in the gut is by production of IgA. And so there are many, many lymphocytes going to plasma cells to make this IgA, which is secreted. Compare that to skin, where we don't have any secretion of IgA. In skin, the lymphocytes are mostly non-secreting T cells. Remember that only 2% of our population of lymphocytes are found in the blood. Of those found in the blood, 80% are T cells. This is a very dynamic group of cells. Naive T cells circulate through the entire lymphoid system of the lymph nodes and the extranodal tissue, like gut, for example, at least twice a day, looking and looking and looking for their cognate antigen and activation. B cells, by comparison, are much more sessile and tend to reside in the lymph nodes and the white pulp of the spleen. So the clinical application of this distribution of lymphocytes is actually important in clinical medicine, because if most of our gut is lined by B cells to produce plasma cells to make IgA, we certainly wouldn't be surprised to that most of our gut lymphomas are B cell in type. By comparison, skin has mostly T cell lymphomas. As we see from the insert, the relationship of lymph node drainage from sites of cancer is one of the fundamental ideas in medicine. Remember, first of all, anytime I have a mass that I can palpate, lymphadenopathy will be part of the differential. The second important idea is that carcinomas, now remember there are 3 kinds of malignancies from 3 different basic cell types. 3 different basic cell types are epithelial cells that make carcinomas, connective tissue cells that make sarcomas, and then our hematopoietic cells from which we get leukemias, lymphomas. So when we're talking about carcinomas, they tend to have a very orderly type of progression. They first go through dysplasia to carcinoma in situ. They invade through the basement membrane. Once they're through the basement membrane into the underlying stroma, they invade lymphatic structures, and from these lymphatic structures they spread in an orderly manner to the nearest lymph node. It's only after spread to these lymph nodes that we see systemic spread throughout the body. So therefore, anytime we have lymphadenopathy, we have to be able to track that lymph node back to the tissue where the cancer is found. Good examples of backtracking from metastases occur, for example, in inguinal lymph nodes. External genitalia, both males and females, drain from and to the inguinal lymph nodes. So if a patient presented with an inguinal lymph node and it had a squamous cell carcinoma, in addition to looking at the leg for the site of the primary cancer, one would also look at the internal genitalia. By comparison, the testicles drain to the periaortic nodes. So if we had a patient presenting with an abdominal mass that proved to be a carcinoma, we would certainly have to look to the testicles as the primary site. A special example of metastatic carcinoma is the left supraclavicular lymph node. This is the so-called Virchow lymph node. Remember that drainage of the foregut, so this is pancreas, stomach, intestine, is into the cisterna chyli, which then drains up through the thoracic duct, and the thoracic duct empties into the venous system in the region of the left subclavian vein, and that's in proximity to the supraclavicular lymph nodes. So when a patient presents with a left supraclavicular mass, and you do a fine needle aspirate and get a diagnosis of adenocarcinoma, the most likely spot that that cancer arose is going to be in the foregut, be it stomach or pancreas or intestine. Another common spot for cancer to present as a mass is in the axilla. The presence of an axillary mass must include the possibility of metastatic carcinoma. And remember, that carcinoma can arise either in the arm or in the breast. So figure 8-1.2b is just a basic way of putting this idea of lymphatic drainage in one's clinical mind. And when we look at it, you should really think of this as two different patterns of lymphatics. You should think of it as the external system, because you can palpate those in everyday medicine. And then you have to differentiate that from that in the body cavity, because you can't palpate them. The only way you can find tumor spread in those is by using imaging. So let's take a look at the important regions of the external lymphatic system that you can palpate as a clinician. Let's start at the head and neck. As we can see, both the left and right sides are going to drain into the anterior cervical lymph node. Remember, cervix is Latin for neck, so the anterior cervical lymph node is in the neck. Compare that now to the breast. I'm here on the left side. On the breast and the arm are both going to go into the axillary lymph nodes. As we move into the abdomen, we can see our foregut drains into the cisterna chyli and up the thoracic duct, where it dumps into the region of the left supraclavicular vein, and we can see there this is our so-called Virchow lymph node. When we come down into the inguinal lymph nodes, remember they can arise either from the leg or from the external genitalia. Now, we'll discuss the internal drainage systems as we do each organ system, but I know that the STEP exam quite correctly has emphasized the lymphatic drainage of a peripheral lung cancer and the lymphatic drainage of a cervical carcinoma. So as you come to each of those two systems, make sure you've paid particular attention to the lymphatic drainage of those organs. So the architecture of a lymph node is seen in figure 8-1.3a. And this is really just a very practical application of the immunology you learned in the immunology system. So let's just walk through how a working clinician thinks about the immunologic signal. We start in the afferent lymphatic vessel. Remember, we've had some sort of event occur in the periphery of this. It can either be antigen for an immunologic response, but it can also be tumor draining in. And so this is going to first drain into the marginal sinus from the afferent vessel. From the marginal sinus, we now see, if this is an immunologic signal, that the signal goes into the primary follicle. And remember, this is mostly naive B cells. With the reaction and stimulation of those naive B cells, we then see the development of our classic immune response. And we can see this as we move down our image and pick up our germinal center in the bottom half of the picture. Now remember, this germinal center represents both proliferation, hypermutation, and then over time, affinity maturation and isotype switching. That's all happening in our germinal center. That is creating B cells that mature into plasma cells. And these plasma cells end up in the medullary sinus. And here in the medulla, they sit for their lifespan of about 21 days and secrete immunoglobulins. As long as there is ongoing signal, then there's ongoing production of those plasma cells with antibody formation. When that signal disappears, perhaps by resolution of the infection, then 3 weeks later we start to see a complete drop-off of plasma cells and a lack of antibody production, and all we're left with at that point then are our memory cells. Note that the paracortex is where most of our T cells are, and the balance between T helper and cytotoxic T cells really depends on the clinical condition. But if, for example, we're looking at a skin disease, which is mostly going to be T cells, skin diseases have marked proliferation in the paracortex that drains the affected area of skin with a rash. So we can see now in figure 8-1.3b the literal histologic example of what we've just been discussing. So as we take a look at this figure, we can see from the cartoon in which we've illustrated, we can see all of the features that are the same. So we can see a well-defined subcapsular sinus. We can see as well a primary or unstimulated follicle. And then we see a really nice example of a germinal center, so that we can see in the germinal center, if we blow this up and look at it, we can see that the germinal center really has two parts to it. It has a dark zone and a light zone. And what we're seeing in that dark zone is we're seeing the proliferation as the cell that has hit its cognate antigen starts to massively ramp up under the stimulation of IL-2. And we can also happening here is our hypermutation, in which we see all those cells doing all the various combinations that they'll need to match the possible antigens. That's quite different than what happens in the light zone, in which we see the processes of affinity, maturation, and isotype switching. Broadly speaking, we can see the paracortex with its T cells, and then we can come down and see the medulla, which is not as well represented here, in which the plasma cells sit and secrete immunoglobulin into the draining lymphatic. Remember that when we talk about the mantle zone, all the mantle zone refers to is what is the residua of the primary follicle. That just represents the naive cells that have not yet been stimulated. The last organ we need to have some understanding of the histology before we start disease is the bone marrow. Remember that when we think about bone, we always think of two patterns of bone. We think about the outside or cortical bone. This is what gives us structural support. So when you're walking along on your legs or you're moving your arm, that strength is coming from the outer cortical bone. And then all the bone inside that is really a sponge-like network of bony trabeculae that make up the medullary bone. And the medullary bone really only exists as a architectural structure for hematopoiesis. If we take a look at figure 8-1.4a, that large pink band coming across the picture is a piece of our trabecular bone. Hematopoiesis then occurs in that milieu. And we can see in architecture there's really two patterns of tissue. We see the large clear spaces, which is nothing more than fat, which is just basically a space filler in the marrow. And then all the areas where we see the blue cellular nuclei, that's actually hematopoiesis. Now, think this through. I can actually sort of blur my eyes and decide what percent of the medullary bone is fat and what percent is hematopoiesis, and that's how we calculate cellularity. So in a normal individual, the amount of fat is about proportional to the age, so that at age 20, your marrow should be about 20% fat, and by age 60 or 70, your marrow should be about 60 to 80% fat. So when you do your bone marrow biopsy for cellularity, that's roughly how it's calculated. Now, bone marrow biopsy allows us to see architecture. That's different than bone marrow aspirate. So as you start your clinical services and you start doing your bone marrow samplings, you're going to see that we introduce a needle, large bore needle, and the first thing you're going to do is put a large syringe on it, and you're going to do quick, hard suction, which fractures little fragments of bone out, and you're going to smear those in a slide, and that's your bone marrow aspirate. And we see an example of that in figure 8-1.4b, in which we can see all the cells of the marrow have been spread across the slide and are represented as individual cells. After you've finished your aspirate, you're going to then take the handle of the needle and you're literally going to drive it into the bone, cutting out an actual core of bone about the thickness of the tip of a pen and typically about 1 centimeter long. And we're going to use that to see the architecture, which is illustrated in figure 8-1.4a and figure 1.4c. So your aspirate is something that you're going to use for actually counting the number of blasts, which obviously is over 20% by definition in acute leukemia. You can take a look at the nuclear cytoplasmic development. That's abnormal in all your megaloblastic anemias. You can look for abnormal maturation function, which is what we see in our pre-leukemias, the dysmyelopoietic syndromes. And you can also see the relative proportion of how much red cell versus myeloid production that there is. As well, because marrow aspirates have individual cells, they're the sample that you're going to use for flow cytometry. By comparison, your bone marrow biopsy gives you architecture. So that's going to be really important for infiltrating diseases like metastases and granulomas of myelopathy. As we've discussed, it allows you to evaluate cellularity. That's going to be about 0 in aplastic anemia. And it also allows you to see fibrosis. So let's just take a moment and look at some of the things we have to be able to do as a medical student from a bone marrow biopsy. In figure 1.4c, you should be able to do two things from this picture. The first is you should see the clear areas which represent fat, and you should be able to give me a rough estimate of what percent fat do I have versus what percent hematopoiesis. Well, you appreciate that's somewhat subjective, but to my eye, that looks to be about 20% fat and about 80% cellularity. And now we have to know age, right? Because percent fat equals age in years. So if this is a 20-year-old, well, that would be about normal. But if that was an 80-year-old, well, that would be a hypercellular marrow. The other thing that you have to be able to recognize from this picture is shown by the arrows. Those gigantic cells are megakaryocytes. And you've never thought about the word. Well, isn't that just a perfect name for it, right? Because you look at these cells, you take a look at the giant nuclei they have. And so it was very nicely named in Latin, mega, large, karyo, nucleus. The last thing to start practicing in your mind as we're coming through our normal marrows is to think through, when a clinician says hematopoiesis, you're always going to think of 3 cell lines, right? You're going to think of granulopoiesis of neutrophils, erythropoiesis, and thrombopoiesis of platelets. So just practice that in your mind. When I say hematopoiesis, you think reds, grans, platelets. So we can see from the page insert the importance of being able to identify megakaryocytes. It's really no more difficult than we've described, and you can really do it having had a few pointed out to you. That's going to be really important because it's the first step you're going to do in thrombocytopenia. Because remember, if we have a decrease in the number of platelets, the differential depends upon, are they down because I'm not making them, there's a fundamental problem with megakaryocyte, usually due to a hematologic bone marrow disease, or are they down because I'm making them, but they're all being consumed? And that's going to be a classic presentation of ITP. Remember, in addition to identifying cellularity and megakaryocytes, the medical student should also be able to recognize fibrosis. Figure 8-1.4d gives a really nice example of that. The stain we do for this kind of fibrosis is classically a reticulin stain, which makes the collagen black. Normal bone marrow should have basically no detectable collagen. But we can see in this picture all of these bands of black fibers, and this would be a good example of early marrow fibrosis. Marrow fibrosis is seen in lots of pathologic process. It's a significant finding, but from a medical student perspective, we're going to show you the most obvious example, which is the myeloproliferative disease, myelofibrosis. Having now reviewed some of the normal findings and processes that we have to have in hematology, let's just talk about how our patients present. Because we really have to break these, as we always do in hematology, into myeloid and lymphoid. So 2.11 cytopenias represent defects of the myeloid process. Remember how we always said when you hear the word myeloid, you always think reds, neutrophils, platelets, because that's how your patient is going to present. If you don't produce red cells, you have anemia. And remember, anemia presents with fatigue. And obviously, if it's low enough, shortness of breath when you exercise. If you don't produce neutrophils, i.e. neutropenia, remember they are the primary cell for fighting bacteria, which is the infections, and the hallmark of bacterial infections is fever. So when I say neutropenia, in your mind you're going to say that patient's going to present with a fever and sepsis. Platelets, you'll remember, actually have a different pattern of bleeding than coagulation factors. Now, coagulation factors aren't affected because they're not made in the bone marrow, so hematopoiesis is quite separate from factor production because factors are mostly made in the liver. Remember that platelet bleeding is epithelial. Epithelium is all of the surface coverings of the body, and we break our epithelia into squamous and glandular. So the great squamous epithelium you can see as a clinician is skin, and bleeding into the skin is classic petechiae. Compare that to bleeding into our mucosal surfaces. If we bleed from the nose, we have epistaxis. If we bleed from the endometrium, we have menometrorrhagia. It's common with platelet abnormalities to bleed from the gums when you brush your teeth. You can bleed from the GI tract. If it's from the stomach, that would be hematemesis. If it's from the colon, it can be fresh bleeding, hematochezia, or bleeding altered by bacteria, which is melena. The common and frightening way of a hematologic death is when platelets are low enough that your patient bleeds into his or her head. That intracranial bleed obviously raises intracranial pressure, and that it can lead to death. Compare that now, 2.1.2, to the presentation of lymphoid diseases. The commonest presentation of lymphoid diseases is big lymph nodes. So lymphadenopathy is a very important finding in lymphoid diseases, and in lymphoid neoplasms, they're painless. The spleen is partially a lymphoid organ, and many processes lead to splenomegaly. The symptoms of splenomegaly include a left upper quadrant fullness, pain if it stretches the capsule acutely, and early satiety because a large spleen can fill the left upper quadrant and decrease the space available to the stomach. Last but not least in lymphoid diseases are the B symptoms. B symptoms are, and this is just so fundamental in medicine, they're all kind of said as one word, fever, night sweats, weight loss. You just sort of, when you say, oh, my patient presented with B symptoms, you're automatically going to pull out this list. It's not a partial list. There's no one else in this list. B symptoms are fever, night sweats, and weight loss, which is typically defined as undesired weight loss of more than 10% maximum weight. So we can see then if our patient presents with abnormal bleeding or fatigue with anemia or an infection, we are thinking myeloid disease. So if we have the suspicion of myeloid disease because of one of these symptoms, how do we prove that it's hematologic in origin? And this goes back to our fundamental laboratory testing process in hematology. We start with a CBC and a peripheral blood smear, and we compare what we see in the periphery to the bone marrow where they're all made. So as we go down the road, this fundamentally tells you how you're going to establish the basic diagnosis in all your hematology patients. So let's take a look at Table 8-2.2 and think about our approaches to the myeloid diseases. When you do the CBC, you can see that we have two basic patterns of diseases. We have the cytopenias at the top with 3 rows, and then we have the proliferations in the next 3 rows, and then last but not least we have our leukoerythroblastic smear. So if there is a peripheral cytopenia and there are no blasts, your patient is going to get a bone marrow examination. And there you're going to see one of 3 fundamental processes. You're going to see an aplastic anemia because there's been destruction of the stem cells. You're going to see a pre-leukemia of myeloid dysplastic syndrome, or you're going to see the megaloblastic anemia of B12 and folate. But take a look at what we see in the bone marrow. Without stem cells and aplastic anemia, the bone marrow is completely hypocellular. So a cytopenia in the periphery with hypocellularity of the marrow is the definition of aplastic anemia. But you know, with our myelodysplastic syndromes and our megaloblastic anemias, we have the ability to try to make the cells, but we don't have the ability to get them to maturation level that they can be released. So this is called ineffective hematopoiesis. And obviously you wouldn't want to confuse the pre-leukemia myelodysplastic syndrome by the megaloblastic anemias, and so you're always going to be ordering your vitamin B12 and serum folate levels. Compare that to a patient presenting with one of our 3 basic myeloid presentations: fatigue with anemia, fever and infection with neutropenia, and bleeding from an epithelial surface and thrombocytopenia. What would we think if we saw an increased cell count in the periphery? Well, the first thing we're going to do, as we always do, is have a look at the peripheral smear. If we see blasts, that's acute leukemia. At the medical student level, the presence of blasts equals acute leukemia. And remember, in the bone marrow, acute leukemia is defined as more than 20% of the marrow cells are blasts. And then later in this, we're going to discuss the differential of acute leukemia. If we see an increase in peripheral count without blasts, then really we have to differentiate myeloproliferative diseases from leukemoid reaction. Leukemoid reaction is just a hyper-physiologic response to infection. That's really different than our myeloproliferative diseases, which are neoplastic. And take a look at what our myeloproliferative diseases are. There's only 4. CML, polycythemia vera, primary thrombocythemia, and primary myelofibrosis. And when you get to your hematology clinics, you're going to find that these are now currently discussed as our BCR-ABL positive for CML and our BCR-ABL negative, or basically our JAK2 positive, for all the rest. The last entity in this table is leukoerythroblastic smear. Remember, leukoerythroblastic smear is the release of immature granulocytes and immature nucleated red cells called normoblasts. They represent fundamental infiltration of the marrow by mass-forming lesions. This falls under the heading of myelophthisis. And in America, that's either myelofibrosis or metastatic disease. Well, laboratory testing, you're going to look at 30 CBCs every day for the rest of your life, and that's going to break into the red cell, white cell, and platelet numbers. So let's just take a look at handling our leukocyte differential. You notice you have to brightly differentiate between our total leukocyte count and then the separate cell types. So in Table 8-2.3, we see this lineup. Note that total leukocyte count is a very different thing than all of the other cell lines. In everyday clinical medicine, you're basically going to say to yourself, check out the neutrophils, compare them to the lymphocytes. Because when you take a look at it, that's over 80% of all your cells. When you look at the neutrophils, you're going to say, Do I see any sign of immaturity? That's what our bands represent. And then really the last one you're going to look at is eosinophils. And eosinophils kind of we can dispose of in a heartbeat because for practical purposes in North America, eosinophils represent allergy or parasite infection. But the next thing to remember is to compare the cell count you have to the total leukocyte count. Because you've noticed in this table we've given you two columns, absolute count and relative count. And the reason we use relative counts really goes back into the historical method by which we calculated the cell count. And because generations of physicians grew up by using relative manual counts, we have a legacy where we often still refer to them by percent. But remember, that's very, very misleading. You've got to take all your percents and convert them to an absolute number. So let's just take a look at why we have to do that. Suppose, for example, I told you, and let's take a look at our normal reference range. Supposing I told you that I had 50% of all my cells were lymphocytes. Well, you would look at what we see in table 2.3 and you'd say, well, 50%, the lymphocyte count is elevated. Well, but supposing I told you the total leukocyte count was 2,000. Well, 50% of 2,000 would be 1,000. My lymphocyte count is normal. The reason they would be up was because I have no neutrophils. So remember, when you see a count, you always have to compare a relative count to the total leukocyte count so you calculate an absolute cell number. Remember as well, depending on where you're practicing, the difference between a manual count and a machine count. If you're doing a manual count, you're only counting 100 cells. That is so small a statistical sampling that it can vary as much as 20%. So if you see a patient from a manual count with 5%, you don't say to yourself, oh, that's increased eosinophils. You repeat it and make sure it just isn't a random statistical variation. The second thing to be aware of as you go to your CBC and you start looking at various counts of white cells is to know whether that white cell count has been derived by machine or by manual technique. Machine-derived counts are based on evaluation of 10 to 20,000 leukocytes and are very precise. Manual counts by comparison are a 100-cell count, and this gives them a precision of about 20%. So you might see an eosinophil count of 5% and say, oh, I wonder if that's an elevated eosinophil count. But in fact, with a 20% variability, it might well be 3% on repeat analysis and completely normal. So be aware that manual counts do not have the same precision as machine accounts. The next idea to pay attention to is this idea of left-shifted maturation. This term comes from a historical legacy of how we used to do white cell counts. When you were doing a manual count, you used to have a machine counter with little buttons for the types of cells. And the counting machine was done on the left hand so that you could manipulate the microscope with the right hand. And as the machine counters were set up all across the Western world, mature neutrophil was thumb, and then a band was the second finger, and so on down the line, so that the promyelocyte was the pinky. So as one started to see more and more immaturity, it was more and more down the fingers of the left hand, and so it was called left-shifted. So left-shifted merely means that you have immature forms, and the importance lies is this is not demargination, as we discussed earlier, but this represents true systemic inflammation. So remember that the peripheral blood smear is just an absolute routine part of clinical medicine, and it has its own vocabulary. And the only way to really master this vocabulary and the morphology which is dependent upon is to just keep repeating it. And so you can see we've set up Appendix 1, which has a table with the leukocyte morphology and the clinical significance. So that's something you just go and practice by yourself, cover up the answers and look at the morphology, and then cover up the morphology and look at the answers until this is vocabulary that's comfortable for you. So let's just close out our understanding of laboratory testing in leukocytes by reminding ourselves about the two basic types of bone marrow tissue that we're going to see. Remember that the biopsy is by a cutting needle that gives you about a 1 millimeter in diameter core that should be 1 to 2 centimeters in length. Now, it is an invasive procedure, and it does hurt, but it allows you to evaluate the architecture. That's really the only way you're going to easily diagnose metastases. It lets you see other structures like granulomas, and really it allows the pathologist to use special stains to look at the various types and proportions of cells. Bone marrow biopsy is the best way to look for myelophysis. It's the best way to evaluate cellularity, and it's really a great way to look for fibrosis. Compare that now to the fine needle aspirate, where we're sucking hard at the marrow and fracturing off small grains of marrow, which we can then smear so that we can see individual cells. This has much lower risk of hemorrhage. If it's all you do, you can do it with a smaller needle. And remember, we can use this for counting blasts. Acute leukemia has to have greater than 20% blasts. We can look for maturation defects. So this is a really good example in figure 8-2.3, and we see what a megaloblastic marrow looks like. We can see in the upper left the red cell nucleus is very immature relative to the amount of hemoglobinization of the cytoplasm. So this is what's called in megaloblastic anemia the nuclear cytoplasmic dissociation. As well, another characteristic cell can be seen here, in which we have a giant metamyelocyte. Those would be very difficult to appreciate off a biopsy. As well, abnormal maturation, like we see in the dysmyeloparetic syndromes, is done off the smears of a fine needle aspirate. We can judge proportion of red cell and myeloid production. And then as well, because they're individual cells, these are great samples for flow cytometry. So when you approach your CBC, you have to be able to understand the differential from the various quantitative abnormalities. And by far and away, the commonest that you're going to see is going to be an increase in neutrophils, or neutrophilic leukocytosis. There's no absolute level that all laboratories agree upon, but typically somewhere between over 7,000 to 9,000 will be the upper range for most laboratories. Remember, you see it in infection, but you can also see it from tissue necrosis, because remember, when we go back into our immunology, we get granulocytosis from infection because of signaling from PAMPs, pathogen-associated molecular patterns, but we also see the release of signaling from tissue necrosis, the so-called DAMPs, damage-associated molecular patterns. And then remember, we can increase our count by causing demargination, and we see that with drugs like steroids and stress situations with epinephrine. Remember the signaling that allows for release of the marrow cells. Cytokines stimulate increased production from the bone marrow and early release. And as that signaling signals more and more need, we're going to start signaling to release not only all the mature forms we have, but also the immature forms. And this is going to give us our so-called left shift. So remember, our basic stimulation is going to be IL-23 to IL-17 to increasing our granulocyte colony stimulating factor, which is going to give us hyperplasia and early release. The basic differential for your neutrophils that are very high in count is going to be leukemoid reaction versus the neoplasm chronic myelogenous leukemia. Leukemoid reaction is an exaggerated response to serious infection. And we're talking serious systemic infections such as a perforated viscus of appendicitis or sepsis. Although that white count might mimic leukemia, remember that the marrow is still normally functioning, so you're not going to see decrease in other cell lines such as anemia or thrombocytopenia. It's extremely common as a pathologist to get a call from a tech who has seen immature granulocytes and she's worried about acute leukemia. The quick way to know whether you've got a serious difficulty is say, is there any change in the platelets and red cells? If there's no thrombocytopenia, it's very unlikely to be a neoplastic change. Remember as well, blasts are the sine qua non of acute leukemia. So in the absence of blasts, it's unlikely that your elevated white count is acute leukemia. The second pattern that you're going to see in leukocytes is our leukoerythroblastic reaction. when there is infiltration of the bone marrow by mass-forming diseases such as the granulomas of tuberculosis, the fibrosis of myelofibrosis, or metastatic infiltration, this normal control of cell release is abnormal. And so we see abnormal immature red cells, which are nucleated. Nucleated red cells are never normal and have to be explained. And we also see immature granulocytes. Remember that in myelofibrosis, we also have an additional finding of teardrop forms, which are thought to be related to the extramedullary hematopoiesis. Figure 8-3.1a shows us an example of a leukoerythroblastic smear. In this, we see a nucleated red blood cell called a normoblast, and we also see immature granulocytes, in this case a metamyelocyte. When you see leukoerythroblastic smear, if you don't have an obvious explanation, shock, resuscitation, massive trauma, then you're going to go do a bone marrow biopsy to see what is causing the underlying release problem. Lymphocytosis is also a common finding in everyday clinical medicine, and they really should be differentiated between lymphocytosis in adults versus that in children. In children, it's almost invariably viral infection and something that really is not going to excite a lot of clinical response. You can see it in some drugs as well, like phenytoin in your epileptics. No surprise that it's due to increased production from immune stimulation. It can also be seen if there's decreased normal transit through lymph nodes, as in pertussis infections. It's very common under this antigenic stimulation, especially most of the viral infections, to see a mildly atypical morphology with open nuclear chromatin pattern and so-called ballerina skirting. Figure 8-3.1b is a really good example of this. In this, you can see that the nucleus has open chromatin. That requires an experienced hematologic eye to appreciate. And then we can see that where the nucleus approaches the cytoplasm, there is this blue alteration in the cytoplasm, and this has been called ballerina skirting. So this is a classic reactive or atypical lymphocyte, which is a sign of profound immune stimulation. While reflexively we think of this as being infectious mononucleosis, in fact you can see it in lots of different infections, from cytomegalovirus and the hepatitis, toxo, and even in acute HIV infections. We know that in acute Epstein-Barr virus infection, infectious mono, one of the hallmark findings on the peripheral blood smear is the atypical lymphocyte. And remember, this atypical lymphocyte is the reacting T cell and not the infected B cell. If you're suspicious of this lymphocytosis in your young adult with a sore throat and lymphadenopathy is infectious mono, you're going to confirm it by serologic study. The commonest test that you're going to do, as we see in the page insert, is the monospot test. This measures heterophile antibodies. Hetero meaning different, phile to love. And that refers to the fact that, for reasons that are completely unknown, the antibodies formed to EBV agglutinate red cells of different species. Currently, we use horse red cells as the substrate, and in the presence of acute EBV infection, we see agglutination. You can see, however, the problem with the monospot test. It tends to have significant false negatives early in the infection, as much as 25% in the first week. Overall, everyday number is about 10% false negative. If you are clinically highly suspicious of EBV infection and your monospot is negative, then you're really going to have to do Epstein-Barr virus specific antibodies. So look at the initials, because they're exactly what you'd think. We typically go testing viruses by looking for their capsid antigens or their nuclear antigens, and this is a good example of that. We have IgM, remember we're looking for acute infection, antiviral capsid antigen, VCA, and a rising titer of viral nuclear antigens, Epstein-Barr virus nuclear antigens, eBNA. Eosinophilia is really sort of a quick and out-the-door discussion. In our part of the world, it's either allergies, asthma, that's from a type 1 hypersensitivity reaction, or systemic parasite infections. So you're not going to see in parasites, for example, that are in the gut like Giardia. It's got to be a systemic infection. Basophilia is quite rare, and when it's seen, it's mostly with myeloproliferative diseases. And surprisingly, one would think that monocytosis would be a useful clinical finding, but in fact it's rarely used in clinical medicine because it tends to be a subacute inflammatory response to fairly obvious clinical processes. Just to remind ourselves about infectious mono and reconnect to microbiology, remember these are highly tested facts on the Step 1 exam. Remember that the virus attaches to B lymphocytes through the CD21 receptor. And remember, when one is looking at the reactive lymphocyte, the so-called Downey cell, that is the T cell. One has to have differentials for elevated cell counts, and one also has to have differentials for low cell counts. Neutropenia is usually defined in most laboratories as a neutrophil count less than 1,500 cells per milliliter. The commonest cause that you're going to see in everyday routine practice is viral infections. This is not well understood, tends to be very transient, and most of the time it's clear that it's a well young child with a virus, and so you're typically going to just note it and not investigate it. If, however, it is persistent or presents with an infection, then the commonest cause is going to be a primary marrow problem with ineffective granulopoiesis. The kinds of causes we're going to see are going to be things like myelodysplastic syndrome, which is seen in elderly patients. Of course, vitamin B12 and folate with our megaloblastic anemias. You can also see it when the bone marrow is replaced by diseases such as blasts in acute leukemia, extensive metastatic disease. This typically has to be a very rapidly developing tumor. One sees it in storage diseases like Gaucher's disease, and obviously replacement of the marrow by fibrosis, which can be primary in myeloproliferative diseases, but also secondary to irradiation and drugs like benzene. Increased spleen, causing hematologic effects, so that's splenomegaly with hypersplenism, is caused by sequestration of the cells in the enlarged spleen. So splenic sequestration can be a cause of neutropenia. Obviously, on the cancer ward, we're going to see chemotherapy because bone marrow is rapidly proliferating tissue, and many of our chemotherapy drugs selectively target mitotically active tissues. There is a familial cyclic neutropenia, and having noted that it existed, it really is beyond the scope of our discussion here. Lymphopenia really isn't something that you investigate much in clinical medicine because it rarely presents as a standalone lab phenomenon. HIV infection with its low CD4 counts certainly show up as a lymphopenia. In DiGeorge and severe combined immunodeficiency, they're low. You can see it in autoimmune diseases. Lupus has a 10% associated rate of hemolytic anemia, but also has findings of immune thrombocytopenia and immune neutropenia. Chemotherapy, glucosteroids, and malnutrition are also associated with lymphopenia. Remember at the beginning of the chapter, we discussed how to think about hematologic diseases of leukocytes by dividing them into myeloid and lymphoid. The myeloid diseases, always think of 3 cell lines, red cells, neutrophils, and platelets. Low red cells, anemia, presents with fatigue. Low neutrophils, neutropenia, presents with bacterial infection with the hallmark of fever. And low platelet presents with bleeding. Well, on the other side, our lymphoid side, the commonest presentation is going to be an enlarged lymph node. So having an understanding of benign lymphadenopathy is a fundamental building block in clinical medicine. When we talk about lymphadenopathy, remember that they fall into 3 fundamental patterns of disease, and we see this in the insert. If the involved lymph nodes are painful, then really this is almost always associated with an inflammatory process, because the inflammation is associated with swelling. The swelling stretches the lymph node capsule, and that results in the pain. If, however, the lymph nodes are painless, then it's much more likely to represent malignancy. So remember, when we talk about the 2 types of malignancy, we're talking about metastatic carcinoma and lymphoma. Metastatic carcinoma is stony hard. If you want to think what that feels like, take your finger and press it against your forehead. That is stony hard. Lymphomas, by comparison, are called rubbery. So think of a rubber ball that you would bounce off the sidewalk, and that's more likely to be a lymphoma, lymphadenopathy. When we talk about the differential acute inflammations that cause lymphadenitis, really we're talking about bacteria like staph or strep. We're talking about things like cat scratch fever from Bartonella. And then there are rare infections such as tularemia from rabbits. You're going to find lots of nonspecific lymphadenopathy, and you might never quite explain them, but you're certainly going to have to rule out neoplasm as an underlying cause. And the general method that this is going to invoke is either going to be fine needle aspirate, because that's very easy to slip a needle through the skin into the node and aspirate some cells. But failing that, then one has to go to biopsy and remove a piece of the tissue for diagnosis. Lymphoid neoplasms are a large and complex group of diseases. And before one jumps in and starts going through the many names of the many types of lymphomas, it's really important to get a higher level view of the discussion. So lymphomas are neoplasms of the lymphocyte family. That's straightforward. But remember, in clinical medicine, we divide them into whether the lymphoma arises in the node, which would be a nodal lymphoma, or it arises in tissue apart from the node. Remember at the start of the chapter, the commonest place to find lymphocytes is either lining the gut, where we find 80% of our lymphocytes, or lining the skin, where we find abundant T cells. These are common sites of lymphoma. They're not arising in lymph nodes, and so they're called extranodal lymphomas. Let's just stop here and note, the commonest of all lymphomas is diffuse large B-cell lymphoma. So if someone presents with a mass that looks like lymphoma, your everyday first expectation is going to be it's a diffuse large B-cell lymphoma. So let's just take a look over at figure 8-4.1a, where we've divided our lymphomas into nodal and extranodal lymphota, and note that in our extranodal lymphomas, we're expecting that mass to be a diffuse large B-cell lymphoma, except, and the exceptions include the stomach, where we're going to see the maltomas, or marginal cell lymphomas associated with H. pylori, in the skin, where we expect them to be T cells, so-called cutaneous T cell lymphomas, and in the sinuses, where we find our natural killer T cell lymphomas. If the lymphoma is arising in a lymph node, then we have the fundamental division of Hodgkin's versus non-Hodgkin's lymphomas. When you're thinking about how to study for the exam, let's take a look at the right column and take a look at this fact. When we take non-Hodgkin's lymphomas, they are number 1 most common, diffuse large B-cell lymphoma, then follicular, then CLL, SLL. Together, those are 70% of the lymphomas that we see in America. If we added a 4th, multiple myeloma, we'd add another 15%. So 85% of all your lymphoid neoplasms fall into those 4 entities, and those are the 4 you have to be really confident in understanding. All the others tend to be just little flashcard diseases that we're going to say, here it is, couple of facts, moving on. When we divide our lymphoid neoplasms then, remember that we're talking about the pre-B and T cell neoplasms and the peripheral neoplasms. That divides us between our acute leukemias and all of our lymphomas. The lymphoid neoplasms in immature cells are our precursor T and B cell neoplasms. And these are really synonymous with acute lymphoblastic leukemia, ALL. So the old nomenclature, which is deeply ingrained into medicine, is to call something acute lymphoblastic leukemia, ALL, but all of your formal written reports are going to describe them as precursor B or precursor T cell neoplasms. Remember that our ALL is our commonest childhood malignancy, and remember, as with all lymphoid, they divide into B cell and T cell, and that's how we think of our ALLs. Most of the ALLs are B cell, 85%. They arise in the bone marrow. They present in childhood and occasionally present as masses. Our T cell ALLs are much less common, and think T cell. What is the natural home of the T cell is our thymus, and that's where these present. And they're in an older age group. They're not presenting in childhood before grade 1. They're presenting in adolescent to young adult males. And because they're presenting in the thymus, they can present as mass effect. Let's just digress a bit and talk about acute leukemias in general. You're going to go to many older textbooks and they're going to lump the acute leukemias together between lymphoid and myeloid. Remember, the fundamental division of hematology is lymphoid-myeloid. So nowadays in practicing hematology, we don't talk about acute leukemias and then decide if they're lymphoid or myeloid. They are lymphoid or myeloid at the get-go. Historically, they were lumped together because they have common clinical similarities. They both crowd out normal hematopoietic cells in the marrow, and that leads to pancytopenia. They both have very stormy acute presentations with a symptomatic onset over a few days to weeks. And that can be so dramatic that both can have infiltration into the marrow that can cause bone pain by stretching the periosteum, and they can both present with headache via the meninges. But remember, they come from fundamentally different cell lines, and they are fundamentally different diseases, however similar their clinical presentations are. So in our lymphoid neoplasms, to come back to our discussion, remember, our B-cell lymphoplasms arise in the bone marrow, and they present because the blast cells literally suppress normal hematopoiesis. That then gives us one of our cytopenias. And here we go again. If it's red cells, that's anemia, fatigue. If it's platelets, it's thrombocytopenia, it's bleeding into epithelium. And it's neutrophils, it's bacterial infection with a fever. That's pretty different from our T cells because remember, they're in the thymus. So the mediastinal mass can press on adjacent structures. If it's trachea, it can be dyspnea. If it's the superior vena cava, it can be superior vena caval syndrome, or it can literally press on nerves and cause chest pain. As well, we can have B symptoms. Remember, the B symptoms is a very tight list: fever, night sweats, weight loss. And in a small proportion of the cases, the cells can pour out into the blood and present as a frank acute leukemia. 90% of all of our ALLs have chromosomal abnormalities. Most of our carcinomas require 7 to 10 mutations to acquire the hallmarks of cancer that we discuss in Chapter 4 that are necessary for metastasis. Hematologic diseases require fewer mutations to achieve that capacity to spread throughout the body. A discussion of all the chromosomal abnormalities in AL is really beyond the scope of our discussion here, but one is worth noting. The translocation 922 that we're all so familiar with in CML is also seen in ALL. And while it is a 922 translocation, it's actually different than the one we see in CML. It's a different fusion tyrosine kinase protein and signifies a worse prognosis than the ALL. Note as well that ALL is more common in Down syndrome. Down syndrome is a very important disease, and it's well worth going through and noting all the complications that are associated with it because they're very testable. ALL is one, the endocardial cushion defects in the heart is another, and the early development of Alzheimer's would be a third. So how do we diagnose ALL? You've got a little child coming in, he's fever, he's got petechiae, and he's complaining of bone pain. Well, we always do it the same way. It's CBC, peripheral blood smear, bone marrow. On the CBC, you're going to see an elevated white count, and the peripheral blood smear is going to show blasts. So there we see figure 8-4.1b with blasts. Now later on in the next chapter under myeloid, we're going to go through the criteria of a blast, but let's just make sure we can do the basics right here. The first important parameter of a blast is it's a really big cell. So take a look at what we're seeing here. Here's a blast, which I'm circling. Look at that. It's about 3 times the size of a red cell. Blasts are big. The second important finding is blasts have a really high NC ratio. That means how much of the cell is occupied by the nucleus. Well, let's take a look at the cell over here on the right. There's my cytoplasm. Look at that. There's only a thin rim cytoplasm. It's mostly nucleus. So that's a high nuclear to cytoplasmic ratio. And from the perspective of someone just learning their morphology, the next big thing that you really want to see in a blast is a prominent nucleolus. So here are two really good examples of nucleoli which are readily recognizable without much experience. Other findings in blasts include immature chromatin patterns and other findings that really require a lot of experience to master. So remember, we're going to find these blasts circulating in the blood in our B ALLs, and they may be present in some of our T ALLs, but otherwise we're going to have to go find them in the mediastinum in the thymus with that disease. Acute leukemia requires mandatory differentiation of lymphoid-myeloid, that fundamental division in hematology. Remember that myeloid, by definition, has granules. That's exactly why we call them granulocytes. And when we talk about the proteins that we find in those granules, one of the really important ones is going to be myeloperoxidase. So myeloperoxidase and the fusion of abnormal granules of our rods are hallmarks of a myeloid leukemia. To diagnose a lymphoid leukemia, we look for the presence of TDT, which is a DNA polymerase only found in lymphoid precursors. And I guarantee you this differentiation of lymphoid from myeloid acute leukemias is so foundational in hematology, no self-respecting exam would not include a question on this. So make sure you're comfortable. ALL has the presence of TDT. AML, acute myeloid leukemia, has either our rods or detectable myeloperoxidase. Well, ALL used to be a death sentence 50 years ago, but now it's one of the greatest success stories in modern oncology. 95% of the children will achieve remission, and 80% will go on to a cure rate. The ones that do poorly have some markers that are worrisome. Favorable prognostic markers are young age. So anyone that's over 12 years of age, that's a higher risk factor. Low blast count is a favorable risk factor. And numerical chromosomal changes such as trisomy are also favorable markers. Recurrence of acute leukemia can recur in so-called sanctuary sites, such as the CNS and the testicle, where there's poor penetration of chemotherapy drugs. When you get more clinical experience, you're going to realize how additional therapy is directed to these special sanctuary site organs. So Table 8-4.1a is a nice summary of our pre-B versus pre-T lymphoblastic leukemias. Commonest is going to be pre-B. It's the commonest childhood malignancy. Remember, it starts in the bone marrow and spreads out into the blood. Remember that the white count typically can be a wide variation from low due to the neutropenia to normal to elevated if there's a high blast count. It has a generally good prognosis, and the symptoms tend to be myeloid, by which we mean pancytopenia. Neurologic symptoms and bone symptoms also occur. That's very different than our T-cell ALLs, which occur in adolescence, occur in the thymus, have a much worse prognosis, and have different symptoms because they're in the thymus. So they're either going to have mass effect in the mediastinum or B symptoms: fever, weight loss, night sweats. So now we move from our immature neoplasms of lymphoid cells to the more mature peripheral neoplasms. The commonest to see in practice is going to be our chronic lymphocytic leukemia, small lymphocytic lymphoma, which for purposes of our discussion and brevity we're going to call CLL-SLL. Let's just talk about that name for a sec. 20 years ago, we recognized that the morphology was similar, but that cell could be seen presenting in the blood, which point we called it a leukemia. But it could also present as lymphadenopathy. And so for decades, these were always separated as two different diseases, depending upon how it presented. But with advances in technology and staining, it was recognized these are just different manifestations of a neoplasm of the same cell. So they've now lumped them all together as a same neoplasm from the common cell that does it. It's important to note that the commonest lymphoma in the United States is diffuse large B-cell lymphoma because it has the highest incidence. It's not going to be the disease that you see most common in practice because the highest prevalence will be CLL-SLL It's an indolent disease. Patients live a long time, and so there are more patients around with the disease to see. CLL/SLL is a disease of the elderly, typically presenting after age 70. Remember that this is a disease diagnosis based on this neoplastic small lymphocyte. They spread very early in the disease and manifest lots of different ways. Most commonly, this is going to be painless, rubbery lymphadenopathy that can well present with immune dysfunction. So it can present with immune dysfunction giving immunodeficiency, which could give us recurrent bacterial infections like pneumonia, or recurrent viral infections like zoster and simplex. But immune dysfunction can also manifest as dysregulation. 10% of these patients are going to develop an immune hemolytic anemia. Well, think how that's going to present. It's going to present with anemia, which is fatigue. You'll get a CBC, which shows a what? Normal MCV. Go back to the algorithm. Next, you want to know decreased production, increased loss, get a retic count. This will be an elevated retic count of hemolysis. And then you'll get, is it immune? You'll get an autoimmune human globulin test or Coombs test, which will be positive, and so you'll see it's an immune hemolytic anemia. Patients can present with splenomegaly. The leukemia can replace normal hematopoiesis in the marrow, so the patients can present with pancytopenia, and the patients can present with B symptoms: fever, weight loss, night sweats. CLL/SLL is a neoplasm that results from accumulation of these functionally incompetent small lymphocytes. These neoplastic cells arrest in maturity at a stage somewhere between pre-B lymphocyte and mature lymphocyte. Right now, that's about as far as research has led us. An abnormal karyotype is found in a majority of these neoplasms, but there's no single mechanism that can be tested. This diagnosis can be made either by investigating lymphadenopathy, which would be done by biopsy. It can be done because the patient has immunodeficiency or an autoimmune disease. But probably the most common way to find it in a hospital is because a CBC shows a sustained lymphocytosis. Any person over age 50 with lymphocytosis over 5,000 cells per milliliter lasting beyond the time of viral infection has CLL/SLL until proven otherwise. Flow cytometry will typically be done as a confirmatory test to show that it's clonal. This is a B-cell neoplasm, so CD1920 positive. Paradoxically, it's CD5 positive, which in a normal cell should only be found on T cells. And then the last test will be a cyclin D1 to rule out mantle cell lymphoma, which has a very similar morphology. CLL/SLL has a really highly variable natural history, and it really depends upon the stage at the time of diagnosis and whether it tends to have high-risk markers or not. Some patients die within 2 to 3 years from complications of the disease, but most patients live 5 to 10 years. Patients with advanced stage, such as having anemia or thrombocytopenia from marrow replacement, tend to have a poor prognosis and death within 2 to 3 years. We don't really have an effective treatment for this disease, and so treatment really becomes palliative and isn't indicated till symptoms develop. There are some significant complications to know about CLL/SLL. The first is that 1 to 3% of these neoplasms will transform into the aggressive, diffuse, large B-cell lymphoma. This is called Richter syndrome and presents because one of the affected lymph node groups starts to rapidly expand. So as you start to care for your CLL/SLL patients, rapid change by increasing of lymph node size is actually very ominous and requires immediate biopsy. Remember that this is a disease of the lymphoid system, and so we see abnormalities of our adaptive immune system. This can be decreased ability with hypogammaglobulinemia, and that's naturally going to present with recurrent infections. About 3/4 of your patient will have some degree of hypogammaglobulinemia, and if it's clinically important, you can treat them with infusions of IgG. As well, they can have dysregulation of the lymphoid system, which gives autoimmune diseases, most commonly an autoimmune hemolytic anemia. Follicular lymphoma is another common neoplasm of the peripheral lymphocytes. It is a very indolent disease, and so it presents as slow, painless lymphadenopathy. Let's make sure we understand the word slow right. These patients might present complaining of a 2 or 3 year history of mass. These tend to be older patients, 60 to 65 years, and about 10% will present with B symptoms: fever, weight loss, night sweats. 80% of these patients will have a T1418 translocation. And remember, this translocation juxtaposes the IGH locus, a very active locus on chromosome 14, with the BCL2 locus of chromosome 11. So this results in the overproduction of BCL2, and remember, BCL2 inhibits apoptosis, and so we see increased survival of the neoplastic lymphocytes. If the role of BCL2 in apoptosis is unfamiliar to you, this would be a good time to go back and review it in Chapter 1. Figure 1-5.2, Pathways of Apoptosis, are important for every student to fully understand. Follicular lymphoma is diagnosed by biopsy. A patient presents with a mass. Masses go to biopsy, and the pathologist gives the diagnosis. The biopsy is going to show small cleaved lymphocytes, and then there are the markers that are useful to think through. This is a B-cell neoplasm, so CD19 and 20 are positive. CD5 is negative. This is not CLL-SLL. BCL2 will be positive because that's the overproduction that's the basis of the neoplasm. These patients tend to live 8 to 10 years. Treatment is mostly for symptoms, and one of the revolutionary changes over the past 10 years has been development of rituximab, which is anti-CD20 and targets one of the classic membrane proteins of the neoplasm, and it's a very effective drug that it probably will have effects on longevity. Diffuse large B-cell lymphoma has the highest incidence of all lymphomas in the U.S. and accounts for about 1/3 of all our non-Hodgkin's lymphoma. It's the most common type of extranodal lymphoma. It arises in organs such as the gut, where the submucosal B cells are very common. Of course, we don't tend to see it as commonly in skin, which mostly use T cells out of our adaptive immune system. There's a rising incidence of primary diffuse large B-cell lymphomas in the brain, and this is presumably due to the increasing longevity of our HIV-infected patients. And remember, these represent reactivation of Epstein-Barr virus. Diffuse large B-cell lymphomas typically present as a rapidly expanding mass in an older person around age 60. Like all lymphadenopathy, we divide them into painful, which is acute inflammatory, stony hard, which is metastatic, and then rubbery with lymphoma. Pathophysiologically, these are a very heterogeneous group of neoplasms, and there's really no well-defined molecular pattern that's testable. About 1/3 of the tumors are T1418 translocation, which suggests that they arise in pre-existing follicular lymphoma. Some have CD5 positivity, which suggests they arose in pre-existing CLL-SLL, the so-called Richter transformation. The most common genetic abnormality is a rearrangement of the BCL6 proto-oncogene, and that transcription factor is found in about 1/3 of cases. Unsurprisingly, the commonest acquired mutation of neoplasm, P53, is commonly found in diffuse large B-cell lymphomas. Diagnosis is made by biopsy. Masses require biopsy, and lymph nodes are no exception, and this will show a diffuse architecture with the large neoplastic cells. Staging now is typically done by PET scanning. Think Warburg effect, anaerobic glycolysis in tumors. And staging is important because more than 1/3 of these cases will have systemic spread at the time of diagnosis. This is an aggressive neoplasm and behaves in many ways very similarly to a carcinoma and has about a 40 to 50% 5-year survival with current treatment. Those tumors that are CD20 positive have a better survival because the treatment can include rituximab, an anti-CD20 antibody. Burkitt lymphoma really has to be thought of in 3 different settings. The endemic form, acquired via EBV, transmitted by mosquito, is seen in equatorial Africa. It typically presents as a mandibular mass in children. Figure 8-4.1f shows the classic presentation of a Burkitt lymphoma in its endemic form. In the United States, it has a very different form as the sporadic form. It typically presents as a rapidly expanding abdominal mass in children. The third pattern is immunosuppressant form seen in HIV individuals. All three forms of Burkitt lymphoma are associated with translocation of 8 to 14 chromosomes. This places the MYC gene on chromosome 8 beside that very active IGH locus on chromosome 14. Remember that MYC is a transcription factor with widespread proliferative activities, including the upregulation of aerobic glycolysis, the so-called Warburg effect. Burkitt lymphomas are the fastest growing human tumors, and the diagnosis in a child really is tantamount to a medical emergency. Diagnosis is by biopsy and shows a diffuse infiltrate of medium-sized malignant cells with numerous macrophages due to the extensive necrosis. These macrophages have a clear appearance relative to the blue nuclei of the lymphoma, and this is called the so-called starry sky appearance at low power. We see an example of this in figure 4.1g. We see the general blue background of our neoplastic cells and the clearness from the abundant cytoplasm of the macrophages throughout mopping up the ongoing necrosis. This is the so-called starry sky appearance. Treatment of Burkitt lymphoma requires intensive chemotherapy, and currently we see a cure rate of about 80% in children. Mantle cell lymphoma is an uncommon tumor that has a similar presentation and appearance to CLL/SLL. It's an important disease for the generation of pathologists that only had morphology, because they struggled with this entity that looks so much like CLL/SLL but had a dramatically worse prognosis. So it was a really important understanding of the disease to identify the 11-14 translocation with the overexpression of cyclin D1, because the generation of older pathologists could now tease out from this very large CLL/SLL group this small population of very aggressive tumors by staining the tumors for the presence of cyclin D1. Marginal cell lymphoma is a heterogeneous tumor that's noteworthy because it often arises in the mucosa as a maltoma, the MALT standing for mucosa-associated lymphoid tissue. Any disease with chronic, long-standing inflammation is at risk for forming a lymphoma. Prominent examples in medicine include gastritis from H. pylori infection, sialadenitis from Sjogren's syndrome, and thyroiditis and Hashimoto thyroiditis. Most of the driver neoplastic translocations in the marginal cell lymphomas are upregulation of the NF-kappa B protein, which promotes B cell growth and survival. Quite extraordinary is the fact that about 50% of the maltomas of the stomach will regress by treating the underlying H. pylori infection with antibiotics. Hairy cell leukemia is a neoplasm of small B cells and typically presents in middle-aged males with pancytopenia and splenomegaly. On peripheral blood smear, these cells have a very characteristic, quotes, hairy, end quotes, appearance due to the cytoplasmic projections. An example of this is seen in figure 8-4.1h, and with a small lymphocyte shows the feathery cytoplasmic margin. These cells are resistant to tartrate on the acid phosphatase stain and were given the name, therefore, as TRAP-positive cells. This is not seen in routine medicine anymore, in which diagnosis is mostly established by flow cytometry. About 90% of the hairy cell leukemias have a BRAF mutation, BRAF, and this should be part of the tyrosine kinase receptor pathway that one should be able to draw from the top of one's head. If that's not possible, it's important to go to Chapter 4 with molecular neoplasia and understand where this sits on that pathway. Hairy cell leukemias have an indolent course, and they respond well to chemotherapy. Table 8-4.1b shows all the important translocations that we currently have in cancer. It's important going into the exam that you cover up the right side of the table, and for each of the lymphomas, describe the translocation. Similarly, it's important that you cover up the disease column and be able to describe the translocation and the oncogene or protein and which of the neoplasms it's associated with. Your Step 1 exam is going to require very little in the way of direct memorization, but this translocation table is one of the areas that you have to do it. Mycosis fungoides and Sézary cell leukemia are part of the spectrum of CD4 helper T cell neoplasms. These arise in the skin where most of the T cells are found, and they clinically manifest according to the amount of tumor volume that's present. With only a small amount of tumor, it really for all the world looks like a rash, a so-called red patch. As more tumor volume builds up, it starts to develop into a palpable raised mass, a plaque, and then it can be actually mass forming in the skin, at which point it's a tumor. Sézary syndrome is a late manifestation of the disease in which the entire skin is diffusely involved, giving an erythroderma, and malignant cells are seen in the blood, giving a leukemia. It's a disease that progresses over many years, but there really are not a lot of effective treatments for it yet. Adult T-cell leukemia lymphomas are neoplasms of CD4 helper T cells that are seen in adults infected by the human T-cell lymphotropic virus type 1. This occurs in those regions where the virus is endemic, most prominently in the Caribbean and in Japan. A virus protein, TAX or TAX, is thought to activate the NF-kappa B pathway. This is an aggressive neoplasm that presents with systemic disease and often also includes skin rashes. Hodgkin lymphoma encompasses a group of lymphomas with features that are actually quite distinctive from the non-Hodgkin's lymphoma. For the purposes of our discussion, we're limiting our discussion to classical Hodgkin's lymphoma. Hodgkin's lymphoma arises in a single node or nodal group and spreads in a contiguous fashion to the surrounding lymph node groups. This is different from our non-Hodgkin's lymphoma, which can often skip to systemic spread. As well, in Hodgkin's lymphoma, extranodal disease is quite rare, unlike our non-Hodgkin's lymphomas. Hodgkin's lymphoma has a very distinctive neoplastic cell, the Reed-Sternberg cell, and 70% of these cases are infected by Epstein-Barr virus. Hodgkin's lymphoma has a bimodal age of distribution. It's one of the most common neoplasms of young adults, and in this age group it typically presents as the nodular sclerosing subtype. Incident peaks again after age 55, but this time as the mixed cellularity subtype. The majority of patients of either type present with painless lymphadenopathy above the diaphragm, which of course most commonly will be our supraclavicular lymph nodes. About 40% of the patients have B symptoms, fever, night sweats, weight loss. Uniquely, drinking alcohol can actually cause pain in the affected nodes. There's really no other disease with this extraordinary finding. The Reed-Sternberg cell is a germinal or post-germinal B cell that does not express immunoglobulins. It's commonly referred to this way as a non-secretory B cell, and this has a close association with Epstein-Barr virus infection. Activation of the NF-kappa B pathway leads to proliferation and a wide production of cytokines. These cytokines are highly produced by this tumor and recruit many inflammatory cells to the lymph node and are responsible for the prominent B symptoms of the disease. Hodgkin's lymphoma is diagnosed by lymph node biopsy and identification of the Reed-Sternberg cell. The Reed-Sternberg cell marks positive for CD15 and CD30. Remember that young adults most commonly have the nodular sclerosing variant, which has broad collagenous bands, sclerosing, divides the nodes so that the lymphoid tissue looks nodal, hence nodular sclerosing. We see this in figure 8-4.1I. At the top of this figure, we see a normal lymph node, and many things about this lymph node should feel familiar to the student. We have well-developed subcapsular sinus. We can see reactive germinal centers. We can see paracortical regions and we can see a well-developed medulla. Compare that to the lower image, in which we see effacement of the nodal architecture by broad fibrous bands, which divides the malignancy into nodes, so-called nodular sclerosing Hodgkin's disease. Figure 8-4.1J shows a characteristic Reed-Sternberg cell with its owl's eye nuclei, and confirmation would be made by staining for CD15 and CD30, which should be present in the cell. Hodgkin's lymphoma is one of the two stagings of neoplasm known to most clinicians, the other being colon. The spread of the disease is very predictable. Remember, it starts in one node and involves that nodal group and then spreads sequentially to the next adjacent lymph node group, so that the disease basically is divided to whether disease is confined to one side of the diaphragm or goes across it. For purposes of staging, the spleen is treated as though it's a lymph node, and bone marrow involvement is treated as though it is systemic spread, that is, stage 4. So note that division across the diaphragm is the most important dividing point. If the disease is on one side of the diaphragm, that is stage 1 or stage 2, then the prognosis is 90% cure. If the disease is present across the diaphragm or systemically, note how the cure rate drops to 60%. Most patients with early disease actually don't die of their Hodgkin's disease, but they die of complications from the therapy. The most important complications include secondary malignancies, as well as heart disease from the chest irradiation. B-cell neoplasms of the plasma cells recapitulate the normal function of plasma cells and secrete immunoglobulins. This monoclonal production of immunoglobulins has multiple names. These include M protein for monoclonal. They can be called a monoclonal gammopathy. They can be called a dysproteinemia, and they can be called a paraprotein. These abnormal, intact immunoglobulins do not filter through the glomerulus. It is very common in a majority of these cases, however, for there to be more production of light chains than heavy chains, and these excess light chains do filter through the glomerulus. Light chains in the urine go by the name of Bence-Jones proteins, and they can be identified as a diagnostic tool. Plasma cell neoplasms tend to occur in two clinical pathologic entities, either as multiple myeloma or as Waldenstrom macroglobulinemia, now also called lymphoplasmacytic lymphoma. Other diseases of plasma cells include plasmacytoma, an isolated mass, heavy chain disease, primary amyloidosis, and monoclonal gammopathy of undetermined significance. Discussion of these entities is beyond the scope of our discussion here. The diagnosis of multiple myeloma is much easier to make if one understands that multiple myeloma is a diagnostic triad. 1. Lytic bone lesions. 2. Paraprotein production. And 3. The proliferation of the neoplastic plasma cells. Understanding the presentation of the disease follows these 3 legs of the stool. Lytic bone lesions can present with pain, really commonly in the spine. One can have pathologic fractures, and lysis of the bone can lead to hypercalcemia. The paraprotein, or M protein, can give hyperviscosity syndrome with headache, blurry vision, and nosebleeds. It's the commonest cause of systemic amyloidosis, and this can present with carpal tunnel syndrome, renal failure, or nephrotic syndrome, or it can actually be an incidental lab finding with rouleau formation on the peripheral blood smear. An example of this can be seen in Appendix 1. The plasma cell proliferation can result in a marrow replacement cytopenia or through immune deficiency, which would present with bacterial infections. Molecularly, multiple myeloma is a very heterogeneous neoplasm. Remember that in addition to the immunoglobulins, the malignant plasma cells can secrete multiple other cytokines. Several cytokines, including IL-1 and MIP-1 alpha, upregulate the receptor activator of NF-kappa B ligand, rank L, and that activates osteoclasts. The osteoclasts obviously are osteolytic, which together with other factors that suppress osteoblasts leads to the lytic bone lesions and hypercalcemia. In the right column note, how would a hypercalcemic patient present? And we see a nice list of how those patients are going to present to their attending physician. Here we can see these discrete, punched out areas of decreased bone formation secondary to Rankel activation of the osteoclasts. Although immunoglobulins cannot clear the glomerulus, the light chains, usually produced in excess in this neoplasm, can. These light chains can directly damage the tubule by toxicity to the renal tubular cells, and they can also form obstructing casts. This leads to so-called myeloma kidney. In addition, the light chains can undergo beta pleating and form amyloid. Multiple myeloma has multiple expressions in laboratory testing. On the CBC, one can see a cytopenia if there's marrow replacement, and rarely one can even see the neoplastic plasma cells as a plasma cell leukemia. On the peripheral blood smear, one sees rouleau. Remember that the immunoglobulins are positively charged, and they buffer the negatively charged red cells so that they no longer repel each other and can form these stacks of coins. In the metabolic chemistry panel, one can see hypercalcemia, and as well one can see an elevated total protein. In the urine, remember that light chains are not detected by the routine dipstick because that only detects albumin. A specific urine protein test has to be ordered. One can do serum protein electrophoresis and immunoelectrophoresis to show the presence of a monoclonal spike. Bone marrow biopsy will show the increased numbers of plasma cells, and by imaging, remember X-ray will show the lytic lesions. The natural history of multiple myeloma is survival for 7 to 8 years. Death is usually from progressive neoplasm, renal failure, infection, or therapy-related myelodysplasia. There's really no standard single treatment established, and treatment is usually based on symptoms. Bone marrow transplant is a final resort. The important complications of myeloma include the immunoglobulin-related amyloidosis, which is seen in as many as 20% of myeloma patients. This presents with purpura around the eyes, presumably due to vascular weakness because the vessels are infiltrated by the amyloid. It can present as nephrotic syndrome from filling up of the glomeruli, cardiac failure, which will be a restrictive cardiomyopathy, or carpal tunnel syndrome because the median nerve has to go through the fixed passage in the wrist. Diagnosis of amyloidosis is made by Congo red stain, which shows apple green birefringence on polarization. There's no acceptable known good treatment for amyloidosis at this time. Renal failure in multiple myeloma can be due to multiple causes, including hypercalcemia, direct light chain toxicity to the tubules, and amyloidosis. In the right column, figure 8-4.1L shows the classic finding of serum protein electrophoresis in this disease. The top image shows a normal pattern, with the largest spike being albumin, alpha 1, alpha 2, and beta peaks, and then the gamma peak representing the immunoglobulins. When we look at the myeloma patient, we see the marked M spike, and perhaps not sharply illustrated in this picture is there is a decrease of all other immunoglobulins in the electrophoresis. Waldenstrom macroglobulinemia is a lymphoma caused by a mature B cell in which a significant proportion of the neoplastic cells will undergo terminal differentiation to plasma cells. Because we see this mixture of mature B cells and plasma cells, the current nomenclature describes this as a lymphoplasmacytic lymphoma. The symptoms from this disease, then, mostly are related to the hyperviscosity from the marked elevation of IgM. Hyperviscosity syndrome presents with headaches, dizziness, blurring of vision. There may be Raynaud phenomenon from cryoglobulins, and there may be bleeding if the IgM interferes with clotting mechanism. Median survival is about 4 years, and there's no specific treatment. We now come to myeloid neoplasms. Let's put this in perspective. Hematology, specifically leukocytes, divide into lymphoid and myeloid. So in our classification of lymphoid neoplasms, we do our immature or pre-B, pre-T cell acute leukemias versus our peripheral, which are most of our lymphomas. Myeloid neoplasms have a very different broad classification. They break into our acute myeloid leukemias, our myeloproliferative disorders, and our myelodysplastic syndrome. So let's start with our acute myeloid leukemias, or AML. Remember, this is a neoplasm of our early hematopoietic precursors in which acquired mutations block normal maturation. Derangements of this normal control of proliferation and differentiation leads to different manifestations of the disease, and these depend upon where in the maturation sequence that defect occurs and the effect that mutation has on differentiation. Over time, myeloid neoplasms tend to become more aggressive. Both our myelodysplastic syndromes, MDSs, and chronic myelogenous leukemias, CML, will go into a blast crisis of acute leukemia. Accumulation of blasts in the bone marrow eventually leads to marrow failure and pancytopenia because blasts suppress the normal hematopoietic stem cells. Presentation, therefore, tends to be the usual presentation of myeloid cytopenias. Decrease in red cells, anemia, presents as fatigue. Decreases in platelets, thrombocytopenia, presents as bleeding on epithelial surfaces. Decreases in neutrophils, neutropenia, presents with bacterial infection and its hallmark, fever. Monocyte blasts distinctively infiltrate tissues and often can present as hyperplasia of the gingiva. AML occurs at all ages of life, but the incidence rises with age, peaking about age 60. So how do we classify our acute myeloid leukemias? The current classification breaks the groups into 3 groups based on etiology. So these are our known genetic abnormality related to myelodysplastic syndrome or related to treatment from other causes, or a 4th group that's nonspecific and tends to be a morphologic classification. In general, however, for the purposes of the exam, there's really only one leukemia that needs to be known. It's going to be the model disease for this entire group, acute promyelocytic leukemia. All of the other acute myelogenous leukemias with genetic abnormalities represent an area of really intense research. It's undergoing such a rapid evolution that really it's very difficult to test in this area. And so the testing tends to evolve on our model disease, acute promyelocytic leukemia, and this is highlighted in our page insert. PML is caused by a 1517 translocation that creates a unique fusion protein from the retinoic acid receptor alpha, RARA, usually called RARA. This blocks the differentiation of granulocytes past the promyelocyte stage. The neoplastic cells often have numerous Auer rods, and in addition to the cytopenias typical for any acute leukemia, PML can present with hemorrhage from DIC. High doses of retinoic acid can overcome the blockage of the retinoic acid receptor by the PML-RARA protein and restore normal maturation. So amongst the acute myeloid leukemias, PML has the best prognosis. Other associations with acute myeloid leukemia, those related to myelodysplastic syndrome and therapy, really do not represent testable entities. The diagnosis of AML, as with all acute leukemias, rests on the identification of blasts. These are usually present in the peripheral blood. Occasional cases they're only present in the marrow, and these are our so-called aleukemic leukemias. Ultimately, bone marrow biopsy is usually performed, and a diagnosis of acute leukemia made when more than 20% of the marrow cells are blasts. CD34, a marker of blasts, is often used to establish a precise bone marrow blast count. Myeloblasts can be differentiated from lymphoblasts by the presence of Auer rods, which are formed from the fused primary granules, or by stains for enzymes found in the granules such as myeloperoxidase. Flow cytometry is commonly used now. Remember that lymphoblasts are characterized by the presence of TDT. Figure 8-4.2a is a very important figure for the test. It shows us two things that a student has to take into the exam. The most important are the crystals seen in the cytoplasm. These represent our rods and are pathognomonic of an acute myelogenous blast. The other is to recognize the general principles of blast identification. First is its size. Look how big our blast cell is. This blast cell that we see here must be 5 times the size of a red blood cell. Remember as well, blasts have prominent nucleoli. They have a very high NC ratio. In other words, if we take the entire size of the cell, what percent of that cell visualized is occupied by the nucleus? When what we see is mostly nucleus, that's a high NC, or nuclear cytoplasmic ratio. In general, students are only going to be asked to recognize a perfectly obvious cell, and the commonest thing to ask is our rods. Acute myelogenous leukemia is a really aggressive disease. Only about 60% of treatment patients will go into remission, and only 15 to 30% are free of disease at 5 years. Promyelocytic leukemia has the best prognosis with an 80% cure rate with pharmacologic doses of retinoic acid. Any disease that arises with acute leukemia from damaged stem cells, such as myelodysplastic syndromes, have a really grim prognosis. Low-risk AML is treated with chemotherapy, but high-risk AML has to be treated with bone marrow transplantation. The myelodysplastic syndromes are a group of clonal disorders causing disordered maturation of hematopoiesis, leading to peripheral cytopenias. Note that the peripheral cytopenia paradoxically has a hypocellular marrow. That's increased cellularity in the marrow, which is the hallmark of ineffective hematopoiesis. You can think of the MDSs as pre-leukemias because they tend to have a high risk of transformation to AML. The myelodysplastic syndromes usually present as cytopenias, and most common is anemia, which of course presents with fatigue. This is a disease of the elderly, and it presents at a mean age of 70 years. Myelodysplastic syndrome can be primary, but it can also be secondary to previous cancer treatment. Alkylating agents, topoisomerase II inhibitors, and radiation are all well-recognized causes. Secondary MDSs are usually designated as TMDS or MDS-T. Myelodysplastic syndrome may be an incidental finding on routine CBC with the presence of a cytopenia, which is usually a macrocytic anemia. This is a good time to go and take a look at the algorithm for anemias and see how the overlapping macrocytosis of megaloblastic anemias and myelodysplastic syndromes are seen in the chart. Myelodysplastic syndromes are diagnosed by demonstrating a peripheral cytopenia with marrow hyperplasia. Note that's characteristic of ineffective hematopoiesis, and as well abnormal morphology in all the cell lines. Neutrophils can show a pseudo-pelgraheuid appearance, and ring sideroblasts are common in the marrow. Chromosome analysis is fundamental in the diagnosis and evaluation of MDSs, and the presence of a rising blast count, defined as more than 5%, represents a high-risk finding. Figure 8-4.2b shows one of the characteristic findings in myelodysplastic syndrome, the so-called ring sideroblasts, in which there's an accumulation of iron in mitochondria, which assume a location around the nucleus. MDSs have a highly variable prognosis, with some patients living over 5 years. If the myelodysplastic syndrome is secondary to therapy, patients rarely live more than a year. The biggest risk for myelodysplastic syndrome is its progression to acute myelogenous leukemia, which somewhere between 10 and 40% of diseases do, and this as well has a poor prognosis. Ultimately, because this is chromosomal defects in the hematopoietic stem cells, the only really reliable treatment is bone marrow transplantation. Myeloproliferative diseases, you'll remember, break into two fundamental families. The family of chronic myelogenous leukemia, which is so-called BCR-ABL, and then the family of polycythemia vera, primary thrombocythemia, and myelofibrosis, which tend to be our JAK2 family or BCR-ABL negative family. This latter family is discussed in the chapter of anemias and hemorrhagic disorders, and presently we're only going to discuss CML. Remember that CML is a neoplasm of granulocyte proliferation. It's most common in middle-aged males and goes through three distinct phases: the chronic phase, the accelerated phase, and the blast crisis with the development of acute myelogenous leukemia. The onset in the chronic phase is very insidious. Patients complain of fatigue, loss of energy, and weight loss. Infection or bleeding from pancytopenia is possible, as well as the symptoms from splenomegaly. CML is one of the very few neoplasms caused by a single specific genetic mutation. The 922 translocation places an oncogene, ABL, from chromosome 9 to a specific breakpoint cluster region, BCR, on chromosome 22. This translocation occurs in the hematopoietic stem cell line. The stems of this crisis can be lymphoblasts as well as myeloblasts. So this is one of the really important facts to carry into the exam. The 922 translocation creates a unique fusion tyrosine kinase, BCR-ABL, that causes granulocytic and megakaryocytic proliferation and the release of these cells in their immature forms by unknown mechanisms. So typically, the chronic phase to the progression to the blast phase occurs over 3 to 5 years. In the chronic phase, the CBC is going to show granulocytosis, anywhere from 20 to 60,000 granulocytes, and is often associated with eosinophilia and basophilia. Because the disease also affects megakaryocytes, thrombocytosis is usually present. On the peripheral blood smear, numerous immature granulocytes are present but not blasts. There is loss of the normal relationship of maturation, and this is characterized by the term the myelocyte bulge. Historically, the neoplastic cells lose enzymatic function, and this was the basis of a low leukocyte alkaline phosphatase stain on the peripheral blood smear. Bone marrow shows a hypercellular marrow with increased myeloid and megakaryocytic cells, usually a mild degree of fibrosis as well. In the chronic phase, the blast count is less than 5%, rising to 20% in the blast phase. Cytogenetics can be done either by karyotype, which shows the T1922 translocation called the Philadelphia chromosome, or it can be demonstrated by FISH testing, which shows the BCR-ABL fusion. Figure 8-4.2d shows the classic peripheral blood smear finding of CML. In it, we can see an increase in the number of white blood cells, and when we look through them, we can see there's a broad spectrum of maturation, from mature forms to metamyelocytes. There are abundant myelocytes as well as promyelocytes. But you notice there is not an increase of blasts. Incidental finding of increase in basophils is often seen in CML. So the natural history of acute leukemia is seen in all CMLs and typically occurs over 3 to 5 years. The development of the drug imatinib has utterly revolutionized the natural history, and it started right away with diagnosis because it prevents this fatal transformation to acute leukemia. The treatment of CML with imatinib really can be seen at 3 levels. We can see it at the level of the peripheral blood smear CBC, which would be a hematologic remission, and these patients really will revert to normal CBCs. We could see it as cytogenetic remission, which would mean you can't detect the 922 translocation. Or we could evaluate effective treatment by biochemical remission, would mean there would be no detectable BCR-ABL fusion protein or abnormal mRNA detectable. Remission is achieved in about 80% of patients. For discussion of the other myeloproliferative diseases, please go to Chapter 7, Red Blood Cells and Bleeding Disorders. Laying hands cell histiocytosis are uncommon diseases of Langerhans cells. In terms of principles, they really illustrate the point that every cell has a neoplastic counterpart, and that with every neoplasm, one must identify the normal cell from which it arises. Langerhans cells, remember, are dendritic cells. They're made in the bone marrow and reside in the skin. Diagnosis of this disease is made by biopsy and is one of the few remaining uses for electron microscopy in diagnostic pathology, because these tumors have these very unique electron microscopic finding of Birbeck bodies. We see a good illustration of this in figure 8-4.3, in which the Birbeck granules are seen, the so-called tennis racket forms. Langerhans cell histiocytosis has three general clinical pathologic entities. There's letter C disease, which is a disease of very young children that presents both in the skin as an eruption of tumor papules and later widespread infiltration of other organs. Intensive chemotherapy gives moderately effective results with 50% 5-year survival. Eosinophil granuloma is an accumulation of the neoplastic cells in the bone marrow, and Hans-Schuller-Christian disease is the triad of skull tumor masses, diabetes insipidus, and exophthalmos from tumor infiltration. The most important disease of spleen is splenomegaly. Splenomegaly is going to be a much more common finding for this generation of doctors who are going to have wide access to ultrasound. When ultrasound becomes part of the routine physical exam, the definition of splenomegaly is going to be when the long axis of the spleen is greater than 12 centimeters. The most important etiology of splenomegaly in our culture is in portal hypertension, in which the increased portal vein pressure results in congestive changes in the spleen. Other causes of splenic congestion include portal vein thrombosis as well as long-standing heart failure. Hematologic neoplasms like the lymphomas and especially the myeloproliferative diseases are associated with splenomegaly. Other causes include storage diseases like Gaucher disease, amyloidosis, and some infections such as acute EBV infection. Splenomegaly can have important systemic effects when it is associated with hypersplenism. Hypersplenism refers to congestion of the blood in the spleen, allowing for cytopenias. Anemia and thrombocytopenia can be clinically significant when enough of the cells are held in the splenic space. Remember as well that large spleens are vulnerable to trauma, causing splenic rupture and fatal hemorrhage. Splenic dysfunction, or autosplenectomy as seen in sickle cell disease, predisposes patients to infections by encapsulated pathogens. Patients without functioning spleens require immunization against these organisms. Thymus really resolves into two patterns of disease. In the congenital disorders, DeGeorge syndrome is perhaps the best known of the diseases. Remember that DeGeorge syndrome now is considered part of the 22q11.2 deletion syndrome, the velocardiofacial syndrome. Thymic hypoplasia and parathyroid hypoplasia are associated with this disease. Remember that it is due to abnormal development of the third and fourth pharyngeal pouches and is associated with varying degrees of T-cell immunodeficiency. In adults, thymic hyperplasia is an important disease which results from diffuse enlargement of the thymus in the anterior mediastinum. Large spleens are physiologic in adolescence, but pathologically can be associated with hyperimmune states such as the connective tissue diseases. Remember that large spleens must be differentiated from neoplasms of the thymus, the thymomas. Important diseases of thymomas include myasthenia gravis, which is discussed under the neuropathies. The page inset shows the autoimmune disorders associated with thymic disease. Most prominent and certainly the most widely tested is myasthenia gravis with its fatigable weakness. Other causes include Good syndrome, which is thymoma with immunodeficiency, pure red cell aplasia, and then a host of immune complex diseases such as Graves' disease, pernicious anemia, dermatomyositis polymyositis, and Cushing disease. The most important neoplasms of the thymus are thymomas. Remember, these are neoplasms of the thymic epithelial cells and not the lymphocytes. It's a favorite question to ask, what is the neoplastic cell of a thymoma, and give you a whole host of choices of T lymphocytes. And that's incorrect. It is the thymic epithelial cells that do the supportive function for T cell maturation. Thymomas are most commonly tumors of adults over 40 years of age, and they present in two different patterns of disease. They can present as a mass effect in the anterior mediastinum, so there can be pressure against trachea giving cough, pressure against nerves giving pain, pressure against the esophagus causing dysphagia, pressure against the superior vena cava causing superior vena caval syndrome, and the recurrent laryngeal nerve causing hoarseness. The other 40% present as myasthenia. Remember, this is muscular weakness, particularly of the small muscles, which are most prominent, the small muscles around the eye. And remember, this weakness is due to fatigability, so that ongoing rapid blinking leads to failure and ptosis. Remember, this is myasthenia gravis is due to autoimmune antibodies to the acetylcholinesterase receptor, and any patient with myasthenia gravis requires imaging of the chest to rule out thymoma. In Figure 8-6.2d, we have a CT section showing us imaging of the anterior mediastinum. And note that we have in the upper surface, we have the manubrium, and then between the brachiocephalic trunk, we have the anterior mediastinal space, which is where we would find thymus. Take this time to review the anatomy of the anterior mediastinum by covering the names and identifying the structures, and then identifying the structures and giving them names. Having studied the chapter on leukocyte pathology, the student should be able to draw out normal bone marrow hematopoiesis and differentiating myeloid from lymphoid maturation. In lymphoid hematopoiesis, the student should be able to differentiate bone marrow from thymus-derived lymphocytes. In myeloid maturation, the student must be comfortable differentiating megakaryocytic erythrocytic maturation versus granulocyte monocyte maturation. The student must be comfortable in understanding the very different presentations of myeloid diseases, presenting as the cytopenias of anemia, thrombocytopenia, and neutropenia, versus the presentation of lymphoid diseases as lymphadenopathy, splenomegaly, and the B symptoms. The student must be comfortable having an approach to abnormalities of the CBC, including cytopenias and proliferative diseases, and how they relate to the peripheral blood smear and bone marrow findings. An approach to lymphadenopathy by imaging and biopsy is an important part of diagnostic medicine. The student must be able to classify the lymphoid neoplasms as the pre-B and pre-T neoplasms, also called acute lymphoblastic leukemia, versus the peripheral lymphoid neoplasms classified as nodal and extranodal, and classification of nodal diseases into Hodgkin's disease and non-Hodgkin's disease. The student should be able to describe the most important lymphoid neoplasms of CLL/SLL, diffuse large B-cell lymphoma, follicular lymphoma, and myeloma by patient presentation, mechanism of disease, and natural history. Students should understand the major categories of myeloid neoplasms, from acute myeloid leukemia the myeloproliferative disease of chronic myelogenous leukemia, and the myelodysplastic syndrome, specifically sideroblastic anemia. The student should be able to discuss the major causes of splenomegaly and the effects of hypersplenism, and the student should be able to describe the diseases of thymic hypoplasia, the 22q11ds syndrome, as well as the causes of thymic hyperplasia and thymomas.